Good morning.
Good morning. How are you?
Good, how are you? I don't know if the sound is, maybe it's my earphone. One second. Chris, can you stop the recording, please? So, good morning, everyone. Thank you all for joining. I'd like to thank Dr. Harrar for joining us today and presenting. So, Dr. Harrar is an associate professor of neurology and pediatrics at the George Washington University School of Medicine in DC. She serves as the director of pediatric critical care neurology and pediatric stroke programs at Children's National Hospital. She attends on the critical care neurology and ICU EEG services and oversees the outpatient stroke and ICU follow-up programs. Research areas of interest include acute pediatric stroke and critical care EEG monitoring. And today she will be talking about management of acute pediatric stroke. Thank you again, and we're all listening.
Good morning. Thank you for that introduction and for inviting me to speak with you this morning. So for the next hour or so, we're going to focus on the management of acute pediatric stroke. I do have a disclosure. I am an editor of an atlas of pediatric and neonatal ICU EEG, and there are images from that atlas in this talk. So, more specifically, our goals over the course of the next hour will be to review the impetus for pediatric acute stroke protocols, to discuss the impact of those protocols on time to diagnosis, and then to highlight some key components of pediatric acute stroke protocols. If we have time at the end, we'll also discuss what we know about neuroprotective measures after arterial ischemic stroke in children. And I will say up front, for those of you who are adult neurologists and particularly adult stroke neurologists in the crowd, you will notice that we are some years behind you in terms of our logistics and our infrastructure and our care. And so I'd love if we have time at the end to hear your thoughts on how we might improve our systems and improve our care for children. And then for the neurology trainees, particularly the adult neurology trainees in the audience, I'm hoping to really highlight some of the key differences between acute stroke care in children versus adults. It's not uncommon for adult neurologists to be called on to provide advice or opine or even direct the care of a child who presents with a stroke to a community hospital or another, institution where pediatrics is folded into the larger adult hospital. And so we often receive children from hospitals out in the community who have been cared for by adult neurologists. So I think important to sort of understand some of the caveats and the differences in terms of what we're dealing with children. So just one slide to sort of set the stage in terms of epidemiology. Pediatric stroke is an important cause of acquired brain injury in children. It has an incidence of 1 to 2 per 100,000 children per year in developed countries, so much lower than the incidences you're dealing with in the adult world. But 50 to 70% of those children suffer long-term neurologic deficits, and 7 to 20% go on to develop epilepsy. So when you think about the age at which these children are having their strokes, those morbidities and deficits really compound over the course of a lifetime. It is also a top 10 cause of mortality in children with a 5 to 10% mortality rate. And that mortality statistics does include both ischemic and hemorrhagic stroke. So, is there anything that we can do about it? So, I don't need to tell this crowd that thrombolysis and thrombectomy have revolutionized the care of adults with stroke, and we are using thrombolysis and thrombectomy in children. And so, over the next few slides, I'll share with you what we know about those treatment modalities in children. You'll see that the numbers we're able to generate in terms of data are much, much smaller than what you're able to generate in the adult world. And for that reason, a lot of what we're doing when we use these therapies in children is extrapolating from the data that you all have in your large adult trials and trying to apply them as best we can, given what we know about stroke in children. So we'll start with a couple studies looking at thrombolysis in children, two of the largest and most recent studies. And when I say largest, you'll get a sense of those numbers and how they differ compared to adult studies. So one of the largest studies that we have looking at thrombolysis in children came out in stroke in 2020. 26 children, 16 stroke centers in the United States, Canada, and Australia. Those children had a confirmed arterial ischemic stroke that was treated with TPA between 2 and 4.5 hours after stroke onset. Those children had an improvement in their median NIH stroke scale score from 14 to 7 after treatment with TPA. And you can see in the figure on the right, part A is the NIH stroke scale score of those children before TPA and then 6 to 24 hours after treatment with TPA. Shown on the right-hand side of that figure is their PSOM score. The PSOM is the Pediatric Stroke Outcome Measure. It looks at 5 domains, including motor function, cognitive function, language function, and behavioral measures. You can see their PSOM score at discharge and then at 3 months and then 1 year later. None of the children in this cohort had a symptomatic intracranial hemorrhage. 2 did have severe nosebleeds. And then one of the numbers that I want to call your attention to is here, this 54% that were treated prior to arrival at the Pediatric Stroke Center that was the focus of this study. And so getting back to that idea that a number of these children are presenting to ERs in the community, they're being treated out in the community. Obviously, you don't want to wait to transfer them to a large children's center to treat them. And again, often that care is being directed and dictated by the adult neurologists who are on call for that larger hospital. A little bit more recently, another study looking at thrombolysis in children, this time published in 2025. 85 children in this study, 27 stroke centers in the United States and Europe with a stroke and an intracranial arterial occlusion. Again, 25 treated with TPA, so similar numbers to the study that we saw on the previous slide. This time there was a comparison group of 65 children who were treated with best medical therapy. And if you look at the table on the right, you can see that those who were treated with TPA had a more favorable pediatric modified Rankin scale score at 90 days, a more favorable PSOM score at 90 days, and a greater reduction in their pediatric NIH stroke scale score over the course of their admission. None of the children treated with TPA had a symptomatic intracranial hemorrhage. And again, if you look at the number, 40% were treated prior to arrival at the Children's Hospital that was the focus of this study. So small numbers, but looks like treatment with thrombolysis may be safe and may be effective in children. What do we know about thrombectomy in children? So there's a large, again, relative, large in our world, registry that's collecting data on children who present with large and medium vessel occlusion, some of whom are treated with thrombectomy, some of whom aren't. That registry is called Save Child's Pro. And their most recent publication looking at their data came out in 2024. 208 children from 45 stroke centers in 12 countries who had a stroke and a large vessel or medium vessel occlusion. In this cohort described in 2024, there were 117 patients treated with endovascular thrombectomy, 91 treated with best medical therapy. In this paper, best medical therapy can include thrombolysis. And you can see from the table on the right that those who were treated with endovascular thrombectomy had a more favorable 90-day modified Rankin scale score, a more favorable difference between their pre-stroke and 90-day modified Rankin scale score, a more favorable PSOM, a more favorable difference between their admission and discharge pediatric NIH stroke scale score, and a more favorable PSOM at hospital discharge. And then you can see the recanalization rates in the lower part of that table. Shown in the lower left-hand part of the screen is the distribution of their modified Rankin scale scores at that 90-day time point. So similar to thrombolysis, fairly small numbers, but does appear to likely be safe. There was only one patient in this study who had a symptomatic intracranial hemorrhage. They were in the EVT group and may be effective. And so we're using these therapies in children. And what might that look like? So this is a patient that we took care of at Children's National. One of the first patients with a large vessel occlusion that we took care of in the thrombectomy era, shortly after I arrived 8 years ago now. And at this point, we had a stroke protocol on paper, but we didn't have any infrastructure, any logistics in place to sort of care for that patient or put that protocol into practice. So this was a 4-year-old who was at school, had acute onset of focal weakness. Her teacher picked up on that right away. She was in our hospital, in our ED, within about an hour of onset of her symptoms. We'll talk a little bit later about MRI versus CT for the acute diagnosis of pediatric stroke. This patient had a pacemaker. That pacemaker was not MRI compatible, and so there was no choice here to be made. She went for CT. You can see her initial CT on the left-hand side of the screen. That was interpreted as normal. But you can see in the middle, her CTA is quite abnormal. She's missing flow out in her right MCA. And you can see that in the 3D reconstruction of her vessels on the right-hand side of the screen, again, missing flow out in that right MCA. So we bolused her with TPA, and then we dripped the remainder in as we flew her to Hopkins. Up until a few weeks ago, we did not have thrombectomy capability at Children's National. Those of you at Washington Hospital Center may be quite familiar with that, as we have sent some of our older thrombectomy candidates to you. Our younger candidates we have been sending to Hopkins. So this patient flew up to Hopkins. You can see her cath angiogram on the left-hand side of the screen. When she arrived at Hopkins, she was in their IR suite in under 6 hours from onset of her symptoms. You can see again, no flow in that right MCA, and then after thrombectomy, you again have flow. She did have a stroke, as you can see in her follow-up CT scan on the right-hand side of the screen. Potentially smaller than it would have been had she not been diagnosed and treated as quickly as she was. So this may make this all look rather simple and straightforward and seamless. I can assure you that it was not. It took 2 neurology attendings and 2 neurology fellows sort of running around like chickens with our heads chopped off in the ED to get this done. And it felt really disorganized and chaotic and uncomfortable. And as we'll talk about in a few slides, this prompted our group at Children's National to work together with the ED to put a code stroke or stroke alert system in place for children who presented in future like this patient did. So what makes acute pediatric stroke care as challenging as it is? So one of the major challenges that we face are delays in diagnosis. So historic data suggests that it takes anywhere from 15 to 24 hours to confirm a diagnosis of stroke radiologically in a child. And some of that delay occurs out in the community, 1.7 to 21 hours from symptom onset to presentation. So, an issue with parents and other caregivers recognizing that stroke is something that can happen in a child, that can certainly contribute to delays. But not all of the delays occur out in the community. There are pretty significant delays even once a child presents for medical care. And some of that occurs due to recognition by providers in addition to parents and caregivers. So there was a large study published in 2009 looking at over 200 children with stroke. And in that study, they found that only 38% of those strokes were suspected by the initial physician caring for those children. We'll get into the issue of mimics a little bit later. There are a number of mimics of stroke in children that can look very much like stroke based on history and clinical exam. And those are more common than stroke in children. So that's one thing that can certainly contribute to this challenge with recognition by the providers seeing these patients. We'll also talk a little bit more about imaging modalities. We do prefer MRI in the acute setting for children, largely due to that issue of mimics and wanting to make sure that we are dealing with a stroke and not one of those mimics before thinking about giving a child something like thrombolysis. But access to MRI can certainly be challenging and can contribute to delays as well, especially when you're dealing with a small child or a child who, for other reasons, may not be developmentally mature enough to lay still for an MRI scan. You're bringing in things like sedation and anesthesia that can potentially contribute to further delays. So getting to that issue of mimics, this is one of the major challenges we face that that sort of contributes to delays and then drives how we think about care, particularly our acute imaging. So if you look at children who present to an ER with an acute onset focal neurologic deficit, many more of them will have a stroke mimic than will have an actual stroke. The most common mimics are migraine and seizure with postictal paresis. And those can be hard to distinguish, again, from stroke just based on history and physical exam alone. Seizures are further complicated by the fact that up to 25% of children with a stroke will present with a seizure. So teasing out whether that seizure is just a run-of-the-mill seizure with a postictal paresis or whether that's your initial manifestation of a stroke can be really tricky. Shown on the right-hand side of the screen is data from Boston Children's looking at the final diagnosis of patients who presented to their ER with an acute onset focal neurologic deficit before and after the implementation of a stroke alert system. If you look in the red box, you can see after they put their stroke alert system in place, 9% of their stroke alerts were actual strokes, 2% were intracranial hemorrhages, 17% were transient ischemic attacks, 35% migraine or other headache, and then 11% seizure. And a number of institutions have reported similar findings. So shown in the upper left-hand corner is data from Vanderbilt Children's Hospital looking at the final diagnoses of patients who had a stroke alert called there. Shown in the lower left-hand corner is the final diagnoses of patients who had a stroke alert called at a hospital in Texas, a children's hospital in Texas. Shown in the upper right-hand corner is data from our institution, from Children's National. If you look at the far right-hand side of that table, you can see that 29% of our stroke alerts turned out to be patients with seizures and a postictal paresis without an accompanying stroke, 26% migraine, and then 10% hemorrhagic stroke, 6% ischemic stroke. And then shown in the bottom right-hand corner is data from a children's hospital in Michigan. So how do children present? Why is this so challenging and why is this so confusing? So a good number of them will present with hemiparesis and hemifacial weakness. So perhaps similar to the way many adults present. But again, that can look very much like a complicated migraine in a child. And when you look at how many children also present with a headache at the time of stroke, 20 to 50%, that becomes a very challenging thing to tease apart clinically. About 20 to 50% will present with a speech or language disturbance, 10 to 15% with a vision disturbance, 8 to 10% with ataxia, 17 to 38% with altered mental status, and then again, up to a quarter of them will present with seizures. So given the availability of a treatment option, in this case thrombolysis, as well as the challenges in terms of timely diagnosis and management, a group of children's hospitals got together in the mid-2010s to attempt a phase 1 clinical trial to look at safety and efficacy of TPA in children. That trial ended up being closed due to low patient enrollment, not surprising when you think about the numbers that we looked at on some of those early slides. It took 10s and 20s of centers to pull together, 25 or 26 patients treated with thrombolysis. But what this study did do was result in the establishment of systems for the evaluation and management of a child with a hyperacute stroke. Most of the children's hospitals in this study, when they started out, did not have any sort of systems or code strokes or stroke alerts in place. So how are those systems performing? So this is data again from Boston Children's Hospital looking at the time from ED arrival to neuroimaging before and after a stroke alert system was put into place at their hospital. We tend to use neuroimaging as our proxy measure in pediatrics for assessing the overall functioning of our system. We just have too few children treated with things like TPA and thrombectomy to use that to sort of gauge how the earlier phases of our process are functioning. So you can see before their stroke alert system was put into place, it took about 200 minutes to get a child from the door of the ED to the imaging suite. And that's a really long time when you think about your window for something like thrombolysis being 4.5 hours. They're spending most of their time just trying to get the child from the door of the ED to the MRI or the CT scanner. After they put their system in place, that time dropped down to around 80 minutes for all comers, down around 50 minutes for children who were thought to be potential TPA candidates based on their age, their presentation, their lack of comorbidities. So, still a long time, still longer than it takes you all in the adult world to accomplish this, but much better than where they started, and in a reasonable amount of time that still leaves you wiggle room to do the other things that you need to do if you're thinking about thrombolysis in a 4.5 hour window. And other children's hospitals have reported similar findings. So 79 minutes from ED arrival to imaging at Vanderbilt, 4 hours from ED arrival to MRI at a freestanding children's hospital in Michigan. 4 hours still quite long, but this hospital started out at 24 hours, so a dramatic improvement from where they began their process. 165 minutes from symptom onset to MRI in France, 60 minutes from neurology evaluation to imaging at Hopkins, and there children are cared for under the umbrella of the same team and system that care for adults who present with an acute onset focal neurologic deficit. 48 minutes from a code stroke to first imaging, and 60 minutes from a code stroke to confirmatory imaging at a children's hospital in Texas. And I think this 48 versus 60 minutes gets at CT versus MRI. Many of those children started off with a CT, often non-diagnostic, as you know, in the very acute stages of a stroke, and then went on to MRI. So this is a depiction of our efforts at Children's National to improve this process. As I mentioned, after that 4-year-old with the LVO, where it took so many of us to accomplish what we did, and it felt so chaotic and disorganized, we set out to improve that process, to make our care better for these children. And so what you're looking at, for those of you who aren't familiar with QI work, is a key driver diagram. So this is essentially a map or sort of an outline of our process at Children's National, working to improve our system from a quality improvement approach. So a group of us from neurology and from the ED got together, said we wanted to improve the management of patients with stroke. We set ourselves a smart aim of decreasing our door to imaging time, again, using imaging time as the proxy for our system. And then we walk through all the steps that we'd have to go through to get a child from the door of the ED to imaging, and identified key points within that process that we thought were likely to have a significant impact on the flow through that system and on the timing of that flow. And we identified as key drivers in our system stroke recognition by the ED care team. We discovered, as we were looking at our process and discussing with the ED and neurology, that there were patients who were presenting to the ED with an acute onset focal neurologic deficit, getting checked in, getting seen by the triage team, and then sent back out to the waiting room to wait for when a room became available. And obviously that was something that we were uncomfortable with and wanted to change. We thought decision support tools would be an important part of our process. The neurology stroke response, when we started out, the neurology trainee overnight or during the day would get a random number page from the ER with no indication of the sort of urgency of that page. It would sort of just get buried with all the other numeric pages that they were receiving throughout the day and night and get responded to in the order that it came in. And so definitely a potential source of delay there. Imaging, data sharing, and resource mobilization. And then on the right, you can see some of the interventions that we pursued to target those key drivers to improve our system. A lot of education in the ED, particularly around the triage teams, a lot of decision support tools, badge cards, EMR prompts, in a dedicated code stroke paging system, an alert system, so that those trainees were not just getting a random numeric page when a patient presented to the ER with concern for stroke. And then we've continued to work on our process through data sharing and reviewing cases together. And so this is what our data looks like. So again, looking at the data from a quality improvement perspective, patient encounters are shown on the x-axis, door to imaging time on the y-axis, and then key interventions sort of highlighted along the top. Shown in the blue is our center line, which is essentially similar to a median. You can see that when we started out, our door to imaging time was greater than 150 minutes. So pretty similar to that door to imaging time that we looked at for Boston. And again, very long if you're, trying to accomplish this care in a timely fashion, particularly if you're thinking about a 4.5 hour window for thrombolysis. And then as we worked through our system and built in our improvements and made our interventions, you can see that we dropped our time from door to imaging to down around an hour. So still longer than we would like it to be, but does give us a little wiggle room and is certainly an improvement from where we started. We started meeting as a task force in August 2020. Our neurology fellow went in-house 24/7, not specifically part of this effort, but something that had the potential to impact our data. So something that we include. Started our educational initiatives in the ED and started meeting as a multidisciplinary group to review cases in October 2021, put our paging system in place in November 2021, and then revived a defunct electronic health record order set in April 2022. For those of you who are QI gurus, this is the MR chart that goes with that data. I'm not going to go into that in detail. One thing that we were wondering as we went through this process and looked at this data was, were we improving time to MRI alone, which tends to be the more challenging imaging modality to obtain in children, or were we also impacting our process when it comes to CT-based imaging? We at Children's National do not have 24/7 MRI, so after hours we are limited to CT and CTA. Often need to get CT and CTA during the day as well if the scanner is not available or if a child is otherwise not able to tolerate MRI for some reason. And we can see that we did impact our time to CTA as well. The trend is fairly similar to what we saw for imaging as a whole, a little bit faster across the board for CT and CTA, not surprisingly. MR chart for those of you who are QI gurus. And then MRI, MRA, similar up around 200 minutes when we started, down around 76 minutes now that we have sort of put these improvements in place. And then another thing that we, wanted to keep track of and keep an eye on was this issue of triage. So when we started this process and put these improvements in place, we mandated that patients who presented with an acute onset focal neurologic deficit concerning for stroke be triaged at an ESI level 1 or 2. And so that means that they go straight from triage back to an ER room and get seen by an ED attending in short order rather than, potentially being sent back to the waiting room like they were when we started. We haven't seen a shift in our center line, although I think if we continue to track our data out, we may see that we are improving our rates of triage at high ESI levels. So that's what things look like currently at Children's National. What about more broadly? How are our other centers accomplishing acute pediatric stroke care? Is it similar to what we're doing? Is it different? A group of us put a survey out a handful of years ago now to try to understand that and to try to learn from each other and help each other build these systems out at our institutions in a way that fits with our sort of local milieu. We had 47 respondents to our survey, most of them coming from freestanding children's hospitals, although there were other types of institutions, including children's hospitals embedded in adult hospitals. Many of them large institutions in terms of our survey respondents, although we did have a smattering of smaller hospitals as well. Just to give you a sense of what the landscape of pediatric stroke looks like, less than half of children's hospitals have a dedicated inpatient stroke consult service. No children's hospital has an inpatient stroke ward like you might find in the adult world. About 3/4 of them have a stroke clinic, and then only about 1/5 of them have a stroke training program. Often that is done in conjunction with an adult neurovascular program. When you look at institutions in terms of whether or not they have a pediatric neurologist with stroke expertise on staff, you can see that there are a fair number of them that don't. And so there are other types of physicians who are guiding this process and guiding this care. We were curious, who responds to the acute stroke page at these hospitals, especially given that there are, institutions without a pediatric stroke neurologist who are putting these protocols into place. You can see that child neurology is the most common respondent, not surprising. I'll call your attention to this number here, the adult neurologists, the fifth bar over. We had 38 centers kind of outline who responds to their acute stroke page. 15 of them included adult neurology. And so I think that gets back to that idea that that adult neurologists are very often involved in managing these children when they present acutely to an ER or on an inpatient floor at a hospital that might be largely adult-based with a small pediatric component. So getting back to imaging, so as I've mentioned throughout, we do tend to prefer MRI in children with a suspected stroke, and that's largely again to differentiate those mimics from strokes. As you're all well aware, a child who presents very acutely is very likely to have a normal head CT, and because of how many mimics are out there and how common they are, we feel in general fairly uncomfortable treating a child with something like thrombolysis without demonstrating that we're dealing with an actual stroke and not a mimic, unless there's some, sort of really high pretest probability that that child's having a stroke, like they have cardiac disease or something like that. If a stroke is present, we use imaging, I think, fairly similarly to how you would use it in the adult world. We want to understand the vascular distribution of the stroke, the size, whether or not there's a DWI flare mismatch to get a sense of timing, whether or not there's a hemorrhage. That's certainly going to impact our decisions around acute treatment, whether or not there's a clot we can go after. And then the other thing that I want to highlight that I think is an important difference between pediatric and adult stroke is over half of pediatric strokes are caused by an arteriopathy. And so that's certainly going to impact how you think about hyperacute treatment and whether that stroke is something that is going to be amenable to something like thrombolysis and thrombectomy. So vascular imaging, really important, not just to sort of highlight where we might have a clot, but to know whether we're dealing with an arteriopathy. So given the challenges related to acute stroke management and imaging in children, the International Pediatric Stroke Study, which is our sort of largest umbrella research group in pediatric stroke, put together recommendations around imaging in acute pediatric stroke. And what they recommended was that for a child with a suspected stroke who was less than 6 hours from last known well, prefer an MRI, but they recommended a limited set of sequences. So a diffusion weighted image, a flare, a blood sensitive sequence, and then an MRA of the head. Sort of the minimum information you need to make a decision about whether or not that child is amenable to acute treatment or not. And so there have been a couple of groups who have looked at these abbreviated sequences in children and how they perform. One group looked at a quick brain MRI, which at their institution was defined as a sagittal, axial, and coronal T2 weighted fast spin echo, and then an axial DWI. They looked at 10 pediatric patients with stroke. The median age of those patients was 3.5 years. So that's much younger than you would normally be able to obtain an MRI without sedation. Usually you're looking at somebody needing to be 6 or 8 years old or even older to tolerate doing an MRI without being sedated. And all of these children were able to do this abbreviated set of sequences without needing sedation. It took about 5.5 minutes to acquire those images, 100% sensitive for stroke, not surprising, given the diffusion weighted image, and they did miss a petechial hemorrhage in one patient. Another group looked at a diffusion plus flare image, 48 patients imaged as part of a pediatric stroke pathway, median age, in this case, a bit older at 12 years, 100% sensitive when it comes to the DWI, 74% specific for stroke. This group felt like flare was useful for identifying some of the stroke mimics that we see, mass lesions, infectious and inflammatory disorders, and metabolic disorders. And so when we asked our survey respondents how they were accomplishing imaging in their children, most of them said they did prefer MRI, again in keeping with the recommendations of the International Pediatric Stroke Study. Most of them were obtaining abbreviated sequence of images, so diffusion, most common, a blood-sensitive sequence, a FLAIR image, and then an MRI of the head. Again, in keeping with those recommendations from the International Pediatric Stroke Study, getting the imaging they needed to make a decision, but not spending excess time in the scanner, especially when dealing with children. Most centers set their goal time to imaging completion under 60 minutes. So again, slower than goal times in the adult world, but I think not unreasonable given that given the data that we've seen from the centers who have described their systems. Most pediatric institutions are able to do an MRI overnight. Most are able to sedate for MRI overnight if needed, and most will interrupt a non-urgent MRI for a potential thrombolysis candidate, but not all. What about advanced neuroimaging techniques, perfusion imaging in particular, commonly used, as you all know, in the adult world to select patients for thrombectomy in an extended time window? Does also appear to be feasible in children and is being used in children. One of the first studies to look at perfusion imaging in children was published by Sarah Lee. She's out at Stanford and sort of leading the charge when it comes to perfusion imaging in acute stroke in children. She first described 12 pediatric patients considered for thrombectomy who had perfusion imaging as part of their care. Did find that thresholds may differ in children as compared to adults. She's now leading a multi-center study looking at the feasibility and utility of perfusion imaging in children. And so more to come from that. We asked our survey respondents whether they were even capable of performing perfusion imaging. We found that most were, but not all. When you look at the overlap of institutions who aren't able to do either CT or MR perfusion, the number is quite small. So most institutions are capable and ready to use perfusion imaging in kids. And so we were curious, whether all this infrastructure and all this work to build these systems was resulting in children being treated with thrombolysis and thrombectomy. We asked our survey respondents how many kids they had treated in the prior year with each of those agents. We found that most had treated one or two patients with TPA in the prior year, although there were a number of centers who hadn't treated anyone with TPA in the prior year. Likely a combination of the delays that we have talked about, but also, as we'll see in a couple slides, the relatively small number of pediatric patients who present with a stroke amenable to treatment with thrombolysis or thrombectomy. We were curious as to what institutions were requiring prior to treating a child with thrombolysis. So if we think back to that study that was done in the mid-2010s to try to look at the safety of TPA in children that was closed, they required that a child have both a demonstrated vessel cutoff and a confirmation of an infarct before they could be given TPA. And so we were curious if centers were still adhering to those strict requirements. And what we found was that over half had shifted away from requiring a vessel cutoff, and I think that makes sense given adult data. But most were still requiring confirmation of an infarct. I think getting back to that idea of not wanting to treat a child with a mimic with thrombolysis. There were a fair number of centers who would treat without confirmation of an infarct. We are one of these, especially given that we're often relying on CT and CTA to dictate care in these children. And then in terms of thrombectomies performed in the prior year, fairly similar, 1 to 2 being the most common number, some centers not having performed any in the year prior to our survey. If we look a little bit more broadly in terms of how many children actually qualify for thrombectomy or are treated with thrombectomy, as well as thrombolysis. This is data from the International Pediatric Stroke Study. So this is from a large multinational registry of children with stroke. This is looking at over 1,000 patients with stroke, divided in the top table by etiology and the bottom table by geographic region. You can see, under 10% of children treated with thrombectomy, depending on etiology. Cardiac disease and prothrombotic disorders tend to be the most common. And then if you look geographically, some differences around the world, although I will say when you look at the data for Australia, all of that data is coming from a pediatric center that is quite advanced in terms of their stroke care, whereas the data in the United States comes from many centers with sort of diverse capacities and capabilities. And then in terms of how pediatric institutions are accomplishing thrombectomy, you can see from this graph that most of them are relying on the neurointerventional radiology team at an adjacent adult hospital. Pediatric interventional radiologists available 24/7 for thrombectomy are pretty rare. As those of you at Washington Hospital Center know, we have been in that bucket of relying on our adjacent adult hospital. We now have a neurointerventional radiologist who will perform thrombectomies locally as of a couple weeks ago. So we've sort of shifted in terms of where we fall on this graph. We will likely still call on you if he is away, or if for some reason we can't get a room or a team together to perform thrombectomy. But you may see our calls dropping off a little bit. And then this just to highlight something that we already mentioned in terms of etiologies of stroke in children. Arteriopathy, far and away the most common, followed by cardiac disease. So again, really important to understand why that child you are seeing might be having that stroke, because you may want to think twice before treating some of these things with thrombectomy or thrombolysis. Okay, so that is sort of the landscape of where things stand in terms of acute pediatric stroke care. I just want to talk about some future directions and some things that we are thinking about in the pediatric stroke community. So one thing that we have been talking about and thinking about is the concept of stroke networks, similar to what you have in the adult world. So, a number of us pediatric institutions have put together these systems and these protocols that function fairly well within our own four walls. But as you've seen throughout the talk, we're getting patients from out in the community, and many of those children are being treated initially out in the community. And so I think we need to think about how we can better care for those children presenting to their local ERs, and how we can fold them into our protocols and our care, whether through telemedicine, telestroke, similar to what you have in the adult world. Other things that we, are thinking about and talking about is can we, or how do we best select children for thrombectomy, particularly in the extended time window? Can we use tissue-based rather than time-based selection, particularly helpful for us given, our delays and our challenges in timely diagnosis. This is just an example of a patient that we did treat late, who ended up doing quite well. This was a teenager who presented about 24 hours after onset of her symptoms. This is her MRI done at 25 hours after her symptoms onset. You can see in panel A, she already has a flare change where she has that infarct. You can see her infarct in C on the diffusion, B on the ADC. We at this point did not have perfusion imaging. We have an ASL here. You can see the asymmetry in terms of her ASL, and then you can see in E that she has a vessel cutoff. And so we spoke to Hopkins about her, and they were willing to take her. So they took her for thrombectomy, and you can see her pre and post thrombectomy angiograms here. And she ended up doing quite well. No extension of her infarct. Hard to know how she would have done had she not had that thrombectomy. Would it have been different? But just something that we that we are thinking about in the pediatric stroke world. And then tenecteplase. I haven't mentioned tenecteplase yet. Um, has largely, if not completely, supplanted TPA in the adult world, as you all know. What about tenecteplase in children? So I would say at this point, tenecteplase in children is pretty spotty. There's a group of us that have been trying to keep track of children treated with tenecteplase. We described our first cohort in neurology in 2025. Looking at 11 children treated with tenecteplase between February 2023 and January 2024, 10 adolescents, one child, no major safety concerns or intracranial hemorrhage. Again, I'll call your attention to the fact that over half of those children were treated at an outside hospital prior to arriving at the large children's hospital that's the focus of this study. And that is sort of anecdotally what we're seeing in terms of tenecteplase in children at this point. Most children being treated with tenecteplase are being treated at hospitals that are largely adult-based that have made the switch over to tenecteplase and are no longer using TPA for acute stroke care. That child rolls up and is similarly treated with tenecteplase. Some children's hospitals have switched to using tenecteplase for their older children, but not their younger children. Many children's hospitals are still using TPA, awaiting further data on tenecteplase in children. I think in the interest of time, I will probably skip neuroprotective measures so that we can have time for question and discussion. I'll just say that I think this is another important area to think about. You've seen the numbers in terms of how many children qualify for and are actually treated with thrombolysis and thrombectomy. So there's a large number of children who don't qualify or aren't treated. And I think things like neuroprotective measures are one way that we can potentially impact their outcome. But we don't know much about them in children. Again, we largely extrapolate from how you handle post-stroke care in the adult world. So skip through those. And then, just in summary, I hope that I've given you a sense of where things stand in terms of acute pediatric stroke care, particularly for those of you who are trainees and may go out and have to care for these children at a hospital that's not a pediatric center. And then I hope I've given you a sense of some of the questions that we are asking and thinking about in pediatric stroke. I just want to thank the group that works with me on acute pediatric stroke care at Children's, the group that worked on the survey with me, and then my email address is here if we don't have time to take your question or your thought. I'd love to hear from you by email. And then the CME credit information is there in the center of the slide as well. Thank you.
Thank you so much, Dr. Harrar, for this outstanding talk, especially for us adult neurologists. It's a great overview. We have a question in the chat, but I'm gonna ask you a question.
Sure.
What is the most common etiology for stroke in children? I may have kind of missed that, but what is the most common in the pediatric world cause for strokes?
Yeah, so the most common cause overall is arteriopathies.
Mhm.
I would say the most common cause of strokes that are amenable to treatment, that have an LVO that get to the hospital in a timely fashion are the cardiac kids. So most of the children that we have treated with thrombolysis or sent to Washington Hospital Center or Hopkins for thrombectomy have been children with cardiac disease, although there have been previously healthy children in that group as well.
Thank you. Let me go with the chat box first. So the first question we have, is there any role of acute cardiac imaging in children with suspected stroke mimic in which head or brain imaging is either negative or not clearly definitive?
So looking for a source of embolus.
I believe that's the main reason for that.
Yeah, that's not something um, that I have heard of anybody doing, but I think that's certainly a good and interesting thought. Yeah, no, I have not heard about any pediatric folks that do that. It's certainly part of our evaluation, but not something that I have heard of anyone doing like in the ED in the hyperacute setting.
So the other question in the chat box is, how often do you have to use sedation to obtain the MRI, and do you have a fast MRI protocol?
Yeah, we have a fast MRI protocol that is sort of similar to the one that I shared as part of the survey and the IPSS recommendations, where we sort of aim to obtain as few sequences as possible to answer our question without leaving the child in the scanner getting extra data that we don't necessarily need for our acute management. Um, Nonetheless, will still be of a duration that is challenging for some of our younger patients and our sort of less mature patients to be able to tolerate. We have the capacity to emergently sedate for MRI. I would say more often we simply revert to a CT and CTA based code stroke in those settings. I think fairly comfortable when there's an LVO. The times when a CT alone becomes a bit uncomfortable is when you don't have a vessel occlusion. You're in the very acute window where you wouldn't necessarily expect a change on a CT. And you're sort of left, oh dear, is this real, or is this a mimic? Most of those situations have come up in our children with cardiac disease, and so given the high pretest probability, we do feel a bit more comfortable treating those children with thrombolysis with a negative CT and without further information.
I think Fernando's here. He raised his hand. If you're unmuted, please go ahead and feel free to ask.
Hi, can you hear me? Hello?
Yes.
Yeah. Oh, hi, Dr. Harrar. Thank you so much for the presentation and excellent information, and also to join us. I just have, well, a couple of questions. So for, I think, well, as adult neurology, we see, or stroke neurologists, we see more like a consistent presentation in these patients, but I wonder how is the education, especially in the ED and the triage, because some of these patients, the pediatric patients, present more with diffuse symptoms or seizures initially, or headaches and altered mental status. So is a way to expedite the suspicion of a stroke in these patients, that they have this clear lateralizing deficit, and kind of what the part of the in the protocol is, when is the threshold to kind of like suspect a stroke in these patients?
Yeah, we have done a lot of education with our triage team and our ED providers, focusing, sort of on the obvious presentations, but also, the awareness that children don't always present terribly cleanly when it comes to a stroke, and that they may have, these more diffuse presentations. Certainly, seizure is something that we have highlighted, to be on high alert with, particularly if it's somebody who's coming in with their first seizure, and they have some weakness in the aftermath of that seizure. And so we continually impress upon our ED to have a very low threshold to call us. We would much rather be called and come and evaluate the patient and have it turn out to not be a stroke than to, obviously to not be called for something that turns out to be a stroke. But yes, that can certainly be challenging, and we have had delays anecdotally in our own system when someone presents with a more challenging presentation, a very not obvious presentation.
Yeah. And my second question is, so if it's part of the protocol to select the imaging modality based on age of the child. For example, if you have a teenager, or like a 15-year-old, you probably can trust that the patient is going to be able to tolerate the CT scan, CTA easily. If you have a younger kid, right, children of, I don't know, 4 years old, in those cases, it's a different protocol. There's a modification. The protocol is modified to kind of expedite the MRI in those patients and sedation in those younger children, or the decision for imaging is based on different, or in other ways.
Yeah, we find it's easiest to get an MRI in our older children because they'll sort of tolerate going in the scanner and be able to lay still. It's the younger children that tend to be the most challenging when it comes
Mm.
to obtaining imaging. And so then the question becomes, do we sedate them and try to get an MRI, or do we just go for CT, CTA? And some of that, to be honest, comes down to logistics in terms of
Mhm.
scanner availability. Is their stomach full? Is anesthesia comfortable? Emergently sedating them, or do we just go with the CT and CTA? And many times we do end up using CT and CTA in those children. I think in an ideal world, we'd love to have the MRI. It just gives us cleaner information, but can be quite logistically challenging.
Yeah, thank you.
A few more questions. One request is if you can show the slide for seizures and stroke.
This one?
I believe yes. Yeah. Dr. Marcus, if you're seeing, do you have any more questions about that? And part of that question is actually, could you please comment regarding seizure and stroke in children's incidence? So basically, what's the
Yeah.
incidence? And it's in the slide, but if you can
Yeah,
mention that.
absolutely. So roughly a quarter of children will present with seizure as their initial presenting symptom. But if you look at the number of children or the incidence of children who have a stroke and then have seizures accompanying that stroke at some point during their course, that incidence ranges from anywhere from 17 to 58%, just depending on the specific population that you're looking at. Seizures tend to be particularly common in the youngest children with stroke, less common in the older children. If you look at patients who are EEG monitored after they have a stroke, which is not all patients, 23% of those who are monitored will have seizures on EEG. We know in pediatrics that a maximum seizure burden of 12 minutes an hour is associated with neurologic decline in critically ill children. There were not enough patients specifically with stroke in that study that looked at that threshold for neurologic decline to say what our threshold for neurologic decline is in patients specifically with stroke. And then we also know that children who have seizures in conjunction with their stroke have a higher risk of going on to develop epilepsy. So that's sort of what we know. There aren't a lot of recommendations from the pediatric stroke guidelines in terms of what to do with that. We don't know whether treatment impacts outcome or how long to treat once treatment is started. I think many of us tend to err on the side of a brief course of treatment for provoked acute symptomatic seizures, but there's a lot of variability in that regard. And then it's recommended in the pediatric stroke guidelines to consider EEG monitoring for children with stroke and altered mental status, but there's not really anything further in terms of recommendations from our guidelines.
There, we have two more questions. One question is about sickle cell and stroke and its importance in pediatric stroke, obviously. And the second part of the question, do you often see this in your center?
Yeah, we do have a large population of children with sickle cell disease, and they are one of our more common presenters to the ED with concern for stroke. I will say rarely, if ever, do we have a patient with sickle cell disease with something like a large vessel occlusion. Usually, it's smaller infarcts or infarcts from their accompanying vasculopathy, whether moya or some other stenosis.
And one last question is, how about dual antiplatelet loading dose instead of TPA in hyperacute setting, if TPA is not practical? And also,
Yeah.
they're thanking you for the talk.
Yeah, that's dual antiplatelet therapy is interesting because that's not something that is that is commonly done with pediatric stroke, and it does make then translating results from adult studies down to pediatrics a little bit challenging, just given that is used so commonly in the adult world and not in children. We certainly do a lot of aspirin, but not as much dual antiplatelet.
Thank you. And I think that's it. Thank you for this great presentation.
Yeah, thank you for having me.
Of course. Have a great day.
You too. Take care.
Bye.